Okay. Good morning, everyone. So welcome to our session, Basic and Clinical Research of Cholangiocellular Carcinoma. I'm Takao Itoi from Tokyo Medical University, and serve chairperson in this session with Professor Shoji Kubo from Osaka Metropolitan University, who was chairman of the committee for the clinical practice guidelines of intrahepatic cholangiocarcinoma published in 2021, 3 years back. Also, we invite this time Professor Katsutoshi Sugimoto from Tokyo Medical University as a discussant. One thing before starting the lectures about the discussion, questions will be accepted after individual presentations. Okay, time is limited, so let's get started. I'd like to introduce the first speaker, Professor Cosmas Lesmana. So, Cosmas, please.
Good morning, dear colleagues, ladies and gentlemen. Thank you, Professor Itoi, Professor Kubo. First of all, I would like to thank the APAS organizing committee to invite me to give talk. It's a very important meeting in a very nice season in Kyoto, Japan. So I will talk on the innovation of clinical management in the hepatocholangiocarcinoma in the era of the systemic treatment. Sorry. So, if we look at the treatment strategy for hepatocellular carcinoma, as we know that the liver cancer is mostly still dominated by hepatocellular carcinoma and small percentage of the cholangiocarcinoma. So, in recent era, that there has been changing in the guideline when now we can use also the systemic treatment for the HCC in the intermediate stage as well as the advanced stage. And we can also do the combination treatment with the local regional treatment. So from our group in the hepatobiliary division, Dr. Cipto Mangunkusumo National General Hospital is the university hospital in Jakarta, in Indonesia. So we have been published about the combination treatment in our HCC patients, and this has been the improvement in 1 year survival rate in the BCLC-A and BCLC-B HCC patients. And also, we showed that the ablation treatment, the RFA treatment, is still can be used also in as an initial modality treatment in combination with another therapy, even in the intermediate stage of HCC. And the response treatment after the ablation has shown to be the independent factors related to survival. So this just, I would like just to show the lesson learned from the HCC patients. The 63 years old female with acute reactivation and acute flare of hepatitis B virus infection. And the abdominal MRI study with Primofis, contrast specific agent for liver, showed the liver cirrhosis with the liver mass at the segment 8. And so then this patient was treated with the oral antiviral and ursodeoxycholic acid. And it shows the significant improvement in liver function in the bilirubin level. And this patient still had a good albumin level and also the kidney function. So because of the large size of the tumor, so in this patient, because also this patient refused for any local regional treatment, so this patient had been planned for the immunotherapy. So, and then the liver function test evaluation conclude the child pool class B9. And after several months before the immunotherapy, because we postponed the immunotherapy due to the acute reactivation of the hepatitis B virus infection. So we did the re-evaluation abdominal MRI with liver-specific contrast agent, showed the slightly higher of diameter of the tumor. However, there was no evidence of the portal vein thrombosis. So this slide just to show that the liver MRI study image is the tumor in the liver. So then we perform the upper GI endoscopy before we continue with the immunotherapy. Then we didn't find any large esophageal varices as well as large esophageal varices. However, it shows maybe possible for a large gastric varices, and also it showed that the mild to moderate gastropathy condition. So we did the EUS evaluation before the cyanoacrylate injection, and we did the cyanoacrylate injection through the EUS guided. So during the treatment follow-up, so we also give the patients albumin correction regularly, and the patient started immunotherapy, no side effect during and after related to immunotherapy, and the liver function test is always seems to be stable. However, after several immunotherapy course, there was a deterioration of the liver function, but it seems like due to the liver cirrhosis condition, and the patient passed away. However, based on the last evaluation, there was no significant progression of liver cancer. So in this session now, we will discuss about more about the cholangiocarcinoma, as we know that there are the two types, that the hilar and also the intrahepatic cholangiocarcinoma. As we can see here, that the grading of the hilar type of cholangiocarcinoma, and based on the NCCN guideline, how can we work up in the extrahepatic cholangiocarcinoma? Of course, we know that the surgical approach seems to be the best treatment for a patient with cholangiocarcinoma. However, in our center in Indonesia, so most patients come already with the advanced disease. So most patients will come with unresectable condition, or maybe even the metastatic disease. So that's why the most patient usually they will need first time for the biliary drainage because of the high bilirubin level, and also we sometimes we did also the biopsy following the guideline, and then to see whether then after that the patient can also receive the systemic treatment or chemotherapy. So we know that based on the guideline that biliary tract cancer, so we have to divide between the locally advanced and then advanced or metastatic disease, where sometimes we need to do the molecular profiling to see whether the patient is very suitable for several innovation treatment. Yeah, I mean, such as like immunotherapy. So this just study a female 66 years old with the hilar stricture. So the chief complaint was a yellowish appearance of skin in the eye 1 week before hospital admission. And abdominal ultrasounds only show the suspicion of dilatation of intrahepatic biliary tract with gallbladder sludge. So, and then the patients underwent the common bile duct stenting during, and then after that, because there's a clogging of stand during the January 2019. Then the second ERCP showed the impression of the cholangiocarcinoma. So then we performed the biopsy through the spyglass cholangioscopy, and the second stenting were performed. So the pathology showed the suspicion of the neuroendocrine tumor, but the immunohistochemistry showed the strongly CA and CK7 positive, and KI 67 positive, and is strongly really positive for cholangiocarcinoma. So then the follow-up MRCP and MRI showed the cholangiocarcinoma or Klatskin tumor, bismuth type 3B or 4. So then the patient underwent the PET-CT scan and showed the diffuse metabolic activity with multiple hypermetabolic nodule on the fourth segment of the liver, suggestive metastasis. And again, that we had to perform the ERCP, and then we changed to the metallic stent for the stent longer patency. However, the patient once went to China for treatment, and in China, the patient underwent the local regional treatment, and still, even though there's a slightly reduced size of the tumor, however, there's still the clear mass with the dilatation of the biliary system. So, and follow-up, looking at there was a ring-enhanced lesion from the MRI follow-up, and also on the periportal segment 6 and 8. And the ERCP showed the irregularity of the region of the hilar. And then because of there was a clogging in the biliary metallic stent, so we cleaned the stent, and then we put one plastic stent inside the metallic stent. So this is just how the blood test showed that how the bilirubin from the normal and then increase and then decrease during the stent exchange, and then become increase again for the progression of the disease. So this is one of the abdominal ultrasound showing this not very clear, only the mild dilatation of the count bile duct. And this is how the MRI showed in this patients. Yeah. And then the ERCP that we perform, and using the placing the metallic stent, and then the next one that we put the plastic stent inside the metallic stent. So I think the issue to be discussed for biliary drainage is whether the ERCP that we should perform, I mean, place covered or uncovered. I think sometimes still debatable, especially in patients with intact gallbladder. Also, the possible sometimes we perform also the endoscopic luminal radiofrequency ablation for stent patency. In very difficult case, sometimes we perform the US guided hepaticogastrostomy for biliary drainage, and maybe that we can also combine the ERCP metallic stenting with RFA, maybe versus the US hepatogastroscopy. So in the intrahepatic cholangiocarcinoma, based on the guideline, also almost the same thing, that the still the definite treatment is the surgical treatment. However, still in the most of patients come also in the late stage with the large size of tumor. So then most of patients will be in the unresectable group, or maybe sometimes they come already with metastatic. So this case, the last case that I would like to show, that the 80 years old female with history of breast cancer that referred to our hospital due to the liver mass with mostly 5 centimeters in diameter. no jaundice, the bilirubin levels is in normal limit, and also only the slightly higher the CEA level, and no hepatitis virus infections noted in this patient, and CA99 is also only slightly or mildly elevated. However, it showed that the increase of the alkaline phosphatase and also the gamma GT. So in this patient, suggested for the percutaneous liver biopsy or the EUS guided liver biopsy. And we educated the family also for the ERCP and count bile duct stenting, possible followed by EUS guided RFA, because this patient is already old. So we talked about the possible one session treatment. So in the one method like endoscopy. So then this patient underwent the ERCP and for the biliary stenting. So because of the age and the patient also has the history of breast cancer, so the family agree only for the palliative treatment. So we placed directly the metallic stenting, and then we performed the EUS guided liver biopsy for the liver mass, and the pathology showed cholangiocarcinoma and followed by the immunohistochemistry at the CK7, CK18, comes 5.2 positive. Also the PDX1 positive, CDX2 positive, and KI67 positive. So the pathologists confirmed that this patient had cholangiocarcinoma. So before the result of the pathology during the EUS guided liver biopsy, so we then followed by the further treatment using the radiofrequency ablation because this patient, the family decided not to receive any chemotherapy. So we performed the EUS guided RFA for the large tumor mass in the liver. So we know that based on the NCCN or ESMO guideline, that the primary treatment option for patient with unresectable or metastatic intrahepatic cholangiocarcinoma will be include the systemic treatment and also consideration of the local regional therapy. And local ablation should be considered for patient with the tumor size less than 3 centimeters who have contraindication to surgery. But in our case, we uh, perform usually even in large tumor size. So sometimes some patient also will refer to the radiotherapy. So as you can see here, also the SBRT also can be considered for patient with intrahepatic cholangiocarcinoma and contraindication to surgery on liver-limited disease in palliative setting. And you can see here that the local regional treatment have been shown can control the progression of biliary tract cancers and could be an option for non-metastatic or advanced disease. So you can see here that there are ablation mostly used for small tumors. Of course, that we have to be very careful, very cautious the location of the tumor, whether it's very close to the bile duct and major blood vessels. And also there are others options such as like embolization when the tumor is too large to be treated with ablation, and also the embolization also could be considered in patient with inoperable intrahepatic cholangiocarcinoma, usually after chemotherapy. And also the radiation treatment also can be used after the surgery or before the surgery as the adjuvant as well as neoadjuvant treatment. So before I stop, so I'd like to invite that there will be meeting in Indonesia and Bali, two meetings in October for the APASO single topic conference on portal hypertension and hepatobiliary malignancy related. Also the FEDW in Bali on November. So with that, I think I thank you very much.
Thank you very much, Cosmas, for a nice presentation with showing the three nice cases. Okay, so time is limited, but firstly is I would like a comment from discussant. Sugimo Sensei, please.
Thank you, Professor Itoi. Thank you for nice lecture. So I have one question, and you mentioned there are two types of biopsy procedure, such as EUS guided or percutaneous biopsy. So how to divide such procedure? How to use EUS guided or percutaneous biopsy?
So still in our clinical practice, we still do mostly the percutaneous liver biopsy. But let's say like in patient, I mean for HCC patient, that usually we still perform the percutaneous liver biopsy. But in the cholangiocarcinoma and especially like HCC with biliary obstruction, so because we will perform the biliary drainage, so nowadays we perform also the EUS guided liver biopsy, followed by the ERCP for the CBD stenting.
I see. Thank you.
Okay, from the floor, Professor Ito.
Yeah, I'm Shun Kaneko from Tokyo Medical Dental University. Thank you for your presentation. May I ask about case one with hepatocellular carcinoma, though it is intercholangiocellular carcinoma session. So case one patient has a HB virus infection. So you choose immunotherapy for patient. However, sometimes immunotherapy occurs HBV reactivation. So you how do you deal with patient for example nucleic acid analog or something? Please tell me.
Thank you for the question. Yeah. So because this patient and most of our HCC patients will receive the long period of the antiviral treatment, and this patient, I agree with you, but this patient is that we observe, we follow up until the liver function is stable, and the patient still continue with the antiviral, and that's what. And we follow up. We observe the HBV DNA level during the immunotherapy, and it seems that to be can be controlled by the oral antiviral. So there's no increase of the HBV DNA or the bilirubin level during the immunotherapy.
Okay, so you mean that you controlled with immunotherapy and observed hepatitis B virus titer?
Yes. Yeah.
Okay, thank you.
Okay, thank you very much, Cosmos.
One more.
Presentation.
Professor Alizu.
I am Shunichi Arizumi from Tokyo Medical University. I have one question. What kind of immunotherapy? So you mean the anti-PD-L1 treatment?
Okay. Yeah. For HCC, now we use the atezolizumab and bevacizumab. And for cholangiocarcinoma, especially in this patient, I know that based on the studies, should be combined with chemotherapy. But because this patient is old, so I just prescribed the durvalumab for this patient, only single immunotherapy.
Thank you very much.
Okay.
Please.
So okay, thank you very much for
Thank you.
your nice presentation. So we have to change to next speaker, Professor Kakegawa from Tokyo Medical College University. The title is Current Diagnosis of Intrahepatic Cholangiocarcinoma from Tumor Localization to Genetic Abnormalities. Please start, Professor Kakegawa.
Thank you very much, Chairman. First, I'd like to thank Professor Shina and Professor Itoi for giving me an opportunity to present this content. Today, I'm going to talk about current diagnosis of intrahepatic cholangiocarcinoma. So I don't have anything to declare for this presentation. So here's today's agenda: the background, screening methods, and risk factors of ICC, and useful tests for diagnosis, the extent of ICC, and tumor biopsy for ICC. So the mortality rate of cholangiocarcinoma is increasing globally. Its incidence is also high in the Asian region. On the other hand, it seems that the mortality rate in Japan is decreasing here. But according to the statistics for cholangiocarcinoma in Japan, the incidence of ICC continues to increase. So the inside of the hepatic carcinoma is still increasing. So internationally as well, there are issues that need improvement regarding the diagnosis and treatment for ICC. So I want to tell screening methods, but unfortunately, there is no effective screening methods has been established. And these early warning signs and these risk factors can be used as a reference of screening, but we should notice almost 40% of patients diagnosed with ICC have no currently identifiable risk factor. So there is some studies. This is using serum proteins to predict the development of cholangiocarcinoma in patients with PSC. These may make it possible to detect cholangiocarcinoma at an early stage in PSC patients, but many studies of this kind have yet to appear. In the treatment of ICC, the availability of surgical resection determines the overall survival of the patients. Also, the tumor size and number of tumor positivity for lymph node, metastasis, vascular invasions are overall survival factors for ICC patients. So accuracy of initial imaging is important in ICC. We should know what tests are useful in diagnosing the extent of ICC. I would like to explain this question with these three kinds of points shown on the slide. The first one is the tumor localization. So ICC presents as a grayish white, well-defined tumor. However, due to the absence of the fibrous capsule, imaging findings often result in unclear tumor boundaries. So these are the B-mode US images and plain CT images of ICC. In this case, the tumor boundaries is clear in B mode. Here is, but sometimes difficult to visualize in B mode with US, depending on the location of the tumor. And the plain CT, this one, shows the tumor as a slightly lower absorption area compared to the surrounding area, but the boundaries is so unclear. So contrast enhanced examination is necessary to detect ICC. The contrast enhanced CT is commonly used for the differential diagnosis and localization assessment for ICC due to its simplicity, widespread availability, and cost effectiveness. Localization is determined by assessing the distribution of regular low absorption areas during the portal and equilibrium phase. So I showed the dynamic CT of the ICC. The tumor with dilation of the intrahepatic bile ducts is observed. In this one arterial phase, the tumor looks heterogeneous faint enhancement, and in the portal phase, it looks like a slightly hyperdense, heterogeneous hypodense area compared to the surrounding tissue. And the last one, here's the equilibrium phase. The interior of the tumor is seen as a slightly hyperdense area here. And this is because cholangiocarcinoma is tumor with abundant fibrous stroma. Therefore, dynamic CT is considered useful for the localization diagnosis of ICC. And also, EOB MRI is useful for the intrahepatic localization diagnosis. The tumor is depicted as a clear low signal area in the hepatocyte phase. This is a EOB MRI image of ICC. It is seen as a low signal on T1 and high signal on T2 weighted images. The MRI provides high contrast resolution, enabling relatively clear image of tumor even without contrast enhanced. In the arterial phase, the tumor enhances it like a ring-like pattern, and in the hepatocyte phase, tumor is seen very clear, low signal. And the last one, the diffusion-weighted imaging shows this one, detection sensitivity has been, no, I'm sorry. Diffusion-weighted image shows restricted diffusion within the tumor. So EOB MRI is considered useful for the localization diagnosis of ICC too. And on the other hand, the contrast enhanced US is at the Kuppa phase demonstrates high sensitivity in detecting ICC, visualizing tumor as distinct defects. But contrast enhanced US still remains supplementary to contrast enhanced CT and MRI due to the presence of the blind areas and issues with reproducibility. In the arterial phase of dynamic CT, it seems like a ring-like enhanced pattern, but while in the US, entire tumor is stained. Reason of this is contrast enhanced US has a high sensitivity of detecting blood flow. Additionally, in the dynamic CT, the tumor has been stained even the equilibrium phase. But on the other hand, the contrast enhanced US, there is a clearly defect shown in the Kuppa phase. So it is important to know the difference in the imaging findings between ultrasound and CT. Accurate lymph node staging is important since it is strongly associated with prognosis of ICC patients. However, detection of metastatic lymph nodes solely by conventional image studies like CT and MRI is challenging since positivity depends mostly on the size and shapes. And Lee showed the PET-CT is better sensitivity at diagnosing lymph nodes metastasis than conventional image studies. This means PET-CT at the time of diagnosis is crucial on the oncological management in cholangiohepatocellular carcinoma. As you can see, the above one, can you find lymph nodes? Yeah, maybe some of you can detect lymph nodes, but here's a PET CT. As we can see clearly where is the lymph nodes is. And below CT, do you know where is the metastasis? Yeah, first time I couldn't find it, but with PET CT, here's the metastasis near the bone. So PET CT is good for detecting lymph nodes and also unsuspected distant metastasis. So next one is the vascular invasion. Meta-analysis revealed that vascular invasion here severe as a significant prognostic factor for ICC. So accurate determination of vascular invasion is very important. With using MDCT with high resolution, the portal vein invasion sensitivity is 89% and specificity is 92%. And also hepatic artery invasion is sensitivity is 84% and specificity is 93%, and both are very high level. And also this is for MRI is deemed to nearly comparable to that of the CT and is equally effective in diagnosis vascular invasion. So this is a dynamic CT on the arterial phase. You can see the encasement of hepatic artery in the arterial phase. And this case underwent surgical resection of the left lobe, and the pathology showed VA2. So it's very good at detecting the vessel invasion. And also, as you can see the tumor here, and here is a zonally contrast in the arterial phase and zonally reduced signal in the hepatocyte phase. So here is a suggestive of vascular invasion with EOB MRI. The third one is bioduct invasion. In intrahepatic cholangiocarcinoma near the hilar lesion, the extent of bioduct invasion should be diagnosed according to hilar cholangiocarcinoma, like here and here. So the EUS and direct cholangiography are useful in diagnosis of extent of bioduct involvements in ICC in the hilar lesion. It is said so. And this is Japanese study, and the only MDCT shows accuracy is to detect bioduct invasion is 79.5, 79.7, and also the biopsy shows 73%, and the MDCT is better than the biopsy, but combined with MDCT plus biopsy, it rises up to the 83.8%. So the mapping biopsy and MCT improves combining is improvement of the positive diagnosis rate. So I will show the ERC. This is an ERC imaging showing intrahepatic cholangiocarcinoma in a hilar lesion. Intercellular opacity is suggested bioduct invasion area observed in the here's white arrowhead area, as you can see. And this is a direct cholangiography was inserted, and as we can see these tumors, and we can perform direct from the cholangiography. So it's very useful sometimes. So the summary is what tests are useful in diagnosis of the extent of intrahepatic cholangiocarcinoma is contrast enhanced CT and EOB MRI are recommended. Okay, next, going to next clinical question. In which cases should tumor biopsy be performed? in ICC? I will answer this first. And liver tumor biopsy is also an option for atypical cases on imaging and non-resected cases that require systemic therapy. So I will talk why I guess so in these three content. The final diagnosis is some cases which imaging findings are very typical, like this, especially with surgical resection is deemed feasible. In these cases, pathological examination is unnecessary and do the operation is correct answer. But atypical cases of intrahepatic cholangiocarcinoma with imaging findings resembling hepatocellular carcinoma has been reported. In liver tumors necessitating system therapy due to their advanced stage, performing a tumor biopsy to determine the most suitable treatment approach is considered reasonable. In such cases, biopsy should be considered. But of course, as you know, there is some adverse events of the liver biopsy. The only complication is a hemorrhage, and probability about hemorrhage is 0.5%. And late complication is peritoneal seeding. It's 2.7%, it said. So important to keep in mind the risk of the bleeding and seeding. So we shouldn't do the operable. Yeah. Resection is available. We don't need to do some biopsies, I think. So the sensitivity of the liver biopsy for the diagnosis of hepatic mass lesion is 89.6 to 97.5 for hepatocellular carcinoma and 92.7 and 95.8% for metastatic liver cancer. A small false positive rate was reported, while 6.4% of false negatives were reported. It is important to keep in mind the possibility of false negatives. To the next content, here is the cholangiocarcinoma gene mutation, schema, and it's very famous. The IDH1 and 2 mutations and FGFR alterations are about 20% in the intrahepatic cholangiocarcinoma, and these agents are already available. And frequency of gene mutation of patients with ICC in Asian and Western, there is a difference with Asian and Western people mutation. Here is compared with Chinese patients and US patients. And as Chinese patients, Asian patients often see the BRCA and the KRAS mutations are very high. And Western patients has IDH1 and IDH2 mutations are quite high. So for personalized systemic therapy, liver tumor biopsies can unveil gene mutation of tumors. And it may be possible to select drugs suitable for systemic therapy for each patient. So this is my summary. The mortality rates for ICC are increasing worldwide, yet there is no effective screening methods available. Accurate initial imaging evaluating may determine the prognosis of the patients with ICC, and contrast enhanced CT and the EOB MRI are useful in diagnosing the extent of the ICC. The liver tumor biopsy is a viable choice for the cases which imaging findings suggest ICC, but they are atypical. We have to check the ICC or not. And for ICC patients who require systemic therapy. Thank you for attention.
Thank you for your nice presentation. Professor Kagegawa presented the brief diagnostic methods for intrahepatic cholangiocarcinoma. At first, would you like to have any comments or questions from Professor Suinoda?
Thank you, Dr. Kakegawa, for educational lecture. I have one question. You mentioned the importance of liver biopsy for cholangiocellular carcinoma. So, however, for gene panel testing, a relatively large amount of tissue should be necessary. So, what kind of biopsy needles should be used for your recommendation?
Thank you for your question. Of course, as you said, we need to obtain the tissues at least more than 1 square millimeter tissues to make a gene test. So we usually use 18 gauge full core biopsy needle, and the length of the biopsy needle is 2 centimeters. And we often obtain the 3 tissues at one session. And that may be the suitable for the gene test. Yeah.
Thank you.
So, okay, Professor Izumi.
Thank you. Very nice, clearly imaging test by ultrasound. So I have just one question. So can you find out in intrahepatic metastasis by contrast ultrasound? If the ICC often spread in the liver by intrahepatic metastasis, the number of multiple the number of multiple can find intrahepatic metastasis and lymph node metastasis by ultrasound.
Thank you. Thank you for your question. The first one, yeah, we can detect the ICC with contrast enhanced US, but sometimes we have to check it is not metastasis from other kinds of organs like colon cancer or some lung cancers. So the blood vessels imaging of the intrahepatic cholangiocarcinoma and metastasis from the other organs are very similar. So in those cases, we often check the biopsy to detect it's ICC or not. And this tiny things, but we can see the under the 1 centimeter tumors in the liver with contrast enhanced. And in the Cooper phase, we can see the very clearly the defect in the Cooper phase. So maybe we can check the metastasis in the liver clearly, I think. And about lymph nodes, maybe Dr. Itoi use contrast enhanced US in EUS, but we don't do so. I'm not sure, but maybe sometimes it's suitable, I think.
Thank you very much.
Professor Izumi, my comment, it's difficult to detect liver lymph node metastasis by using ultrasound. So I usually use PET-CT or CT. It should be necessary.
Thank you very much.
Is there any comments or questions? So as Professor Kakegawa said, there is no effective screening for intrahepatic cholangiocarcinoma. Some patients with intrahepatic cholangiocarcinoma are infected with chronic hepatitis C or B. So during the follow-up screening for hepatocellular carcinoma in such patients, do you recommend measure CEA or CA99 as well as alpha beta protein or PIVA2?
Thank you for question. I'm wondering too, but I sometimes check the CA and CA99 because those tumor biomarkers are not only for the ICCs, like colon cancers and gastric cancers. So sometimes I do, but at least one times in per year, maybe. Yeah, but I don't have evidence of we should do so or not. Yeah.
Okay,
I'm
thank
sorry.
you very much. So it's time to move to the next speaker. Please, Professor Itoi.
Okay, so let's move on to the third lecture by Professor Shun Kaneko from Tokyo Medical and Dental University. So Kaneko-sensei, please.
Oh, thank you, Chairperson and President. I'm Shun Kaneko from Tokyo Medical Dental University. This is the agenda. First, liver function and prognosis of ICC, and second, systemic treatment with immune check inhibitor for ICC. The third, genome target therapy for ICC. Background, cholangiocarcinoma is the second most common liver cancer after hepatocellular carcinoma. And globally, the incidence is high in East and Southeast Asia. The incidence in Japan and Western country has also been on the rise in the recent years. According to the 23rd Japan National Primary Liver Cancer Follow-up Report, ICC account for 6.9% of primary liver cancers. A previous result has shown the risk factors are slightly different between ICC and extrahepatic cholangiocarcinoma. In ICC, there are coronary disease, PSC, cirrhosis, liver fluke, hepatitis B and C. The only curative treatment is surgery. However, due to a rate of manufacturing of ICC, fewer than 1/3 patient eligible for surgical resection. So 2-year relative survival ratio is 17.3% in ICC patient with stage 4. So ICC is a very aggressive malignancy. This is a real-world study for prognosis of ICC. A total of 83 ICC patients were recruited respectively from March 29 to August 2020 in Musashino Red Cross Hospital. Liver function was assessed by Child P class and LV score, and extent of tumor, portal vein tumor thrombosis classified from VP0 to 4. A total of 70 Child P grade A patients were present in all groups. Our score was minus 2.480. And this was lower in resection group compared to non-resection group. Interestingly, more cases of viral hepatitis were present in the resection group and than in non-resection group. The median LV score of patient with VP3-4 was higher than VP0. This means liver function of VP0 was better than VP3-4. Survival curve, according to the LV grade, median OS was longer for those with better LV grade. The extent of PVTT also significantly stratified overall survival. Based on the result, the liver function and extent of PVTT was identified as the prognosis factor of ICC patient. Next, we investigate prognosis factor of patient with ICC with univariate and multivariate analysis. In univariate analysis, CA99, tumor sites, multiple tumors, lymph node metastasis, PVTT, and lower RV grade, the significant prognosis factors. In multivariate analysis, the only lower LV score is an independent factor of prognosis ICC patients. As previously reported, the median overall survival of resection group was significantly longer than non-resection group. And RB score also a prognosis factor in ICC patient without basic chronic liver disease and non-resection group respectively. So the RB score is a very important factor of ICC patients. Next, systematic treatment with immune checkpoint inhibitor for ICC. This is a famous phase 1 trial. Durvalumab plus GC group showed prolonged overall survival than placebo plus GC group. And objective response was higher in Durvalumab plus GC group, and progression-free survival has been prolonged. Immune-related adverse event, very important because this is an area where this is not have been used ICI. IRA were observed in 20.7%, and the incidence of grade 3 or 4 IRA was 2.4% in the Durvalumab plus DC group. This is our retrospective study about immune-related liver injury. So regarding liver injury, IRLI, a total of 26% patient, 4.5% had grade 2 liver injury at median onset of 58 days. And 24 patients, 4.2% had a grade 3 or higher IRLI at median onset of 56 days. Overall survivor, patient who experienced IRLI, AE or IRLI, has been prolonged. These data show appropriate follow-up and control of the IRLI can improve prognosis. Objective response improved. I want to show a case of convergent surgery of ICC after GCD. This is a male in 70s. ICC located in the anterior and the medial segment. PET-CT show a large para-aortic and portohepatic lymph nodes. After many administration for course of GC and 3 course of GCD, partial response was achieved. After 6 courses GCD, convergent surgery was performed. He had no recurrence till now. Next, germ target for biliary tract cancer. As specific ICC mutation genes, there are FGR2, NTRK, IDO, IDH1, 2, APHA, BAF1 mutation. The FGR fusion gene has been reported in 13% in ICC in overseas and 7.4% in Japanese reports. Recent years, comprehensive genetic profile using liquid biopsy has been expanding. So for good detection length, a pathological mutation, gene mutation was observed in the liver and cholangiocarcinoma. This is a female in her 50s. A large tumor on the right lobe of the liver, a multiple bone, a liver tumor, a lung tumor, a multiple enlarged lymph node, peritoneal dissemination. According to the decline performance status, S1 was administered first-line therapy. Then after, GC therapy was performed for 10 months. However, progression disease was occurred. However, we want give her to treatment option. A CGP was performed by using a liver tumor biopsy and lymph node biopsy. However, a viable specimen was not obtained. Finally, liquid CGP was performed. Finally, FGR fusion mutation was detected and lead her to receive pemigatinib as a third-line therapy. After initiating pemigatinib, CT scan shows stable disease, and however, specific side effect was occurred. Nail disorders classified grade 3 lead her to reduce pemigatinib 9 milligram per day. Finally, she experienced repeated cholangitis and severe side effects. The medication withdrawal are needed. Finally, she arrived to 26 months since diagnosis ICC stage 4. I want to show our data shown in APSL 2022. Over 400 patients was analyzed by CGP. This data include 6 patients with HCC and 11 patients ICC, including 8 cases with hepatic portal region. This is result and overview. Intrahepatic ICC pathogenic mutation was detected. Most frequent TP53 is the most frequent gene mutation. And KRAS and BRAF NF1 associated with MAP kinase signal pathway detected also in ICC. As action of mutation, this result was found. I want to show a case with tumor mutation burden high. This is a male in his 60s, a large tumor on the posterior right lobe, multiple enlarged lymph node include para-aorta. After initiation, GC progressive disease was occurred. However, CGP showed a tumor mutation burden high, so lead him to receive pembrolizumab and radiation therapy for lymph nodes. Finally, objective response was achieved. So he decided to receive conversion surgery, but posterior segmentectomy. Surprisingly, pathological complete response was achieved. Thus, an advancement in genomic analysis and systemic therapy can lead patients for more treatment options and improvement their prognosis. This is summary. Background liver disease and liver function also focus on the prognosis associated with ICC patients. Combination of ICI with chemotherapy has shown significant improvement in overall survival, progression-free survival, and objective response rate. Second-line therapies are available to target pathways associated with specific gene mutations. Though resectable ICC exhibit a very poor prognosis in the past, the development of novel therapeutic agent in appropriate approach may improve prognosis of patients with ICC. Thank you for attention.
Thank you very much, Kaneko Sensei, for showing the very nice summarizing the current situation of the treatment of the in patient with the ICC. Okay, so let's open discussion. The first is Sugimoto Sensei. Any comments, please?
Thank you, Professor Itoi. I have one question. You mentioned that PVTT is a critical factor for patient prognosis. So, however, I'm not infrequently encounter such PVTT in ICC. So, is that special types of ICC, such as combined hepatocellular carcinoma and cholangiocellular carcinoma?
Yeah. However, it's very difficult because all of them have received surgery or liver biopsy. However, the typical characteristic of radiology. So we defined ICC, normal ICC, I think. However, as you mentioned, ICC have less PVTT than hepatocellular carcinoma. I think so too.
Thank you.
Okay, Professor.
Yeah. Okay. Yeah, very nice presentation, Dr. Kaneko. I would like to ask because in Japan, you do a lot of surgical resection for the tumor, especially for cholangiocarcinoma. So my question is whether the portal pressure is always measured before surgical resection, and how do you measure it, and during the surgery or before, or and then in what level of portal pressure that you, I mean, you do surgery or not?
Okay. Thank you for your question. So I think it's depend on the degree or the cause of portal hypertension. For example, so portal hypertension sometimes occurred by tumor thrombosis. However, Japanese surgery very excellent. So they decide to choose surgery for treatment both of tumor and TVT portal hypertension. I think it should be perform surgery. However, sometimes it's difficult to go to surgery. First, as a physician, we physician treatment with portal hypertension with endoscopy or something physical treatment, I think.
Thank you.
One more.
Okay. Please.
Thank you for very wonderful presentation. And I have one question. I'm very interested in TMB high patients, and the patients receive the resection of the liver. And I have now I have one patient. I want to conversion therapy for the ICC patients. And is there any is there any recommend of the conversion therapy for the patients in your institution? Like the tumor marker is normal and there is no any metastasis with PET CT or something. Please tell me.
Yeah, thank you for your question. It's a very hot topic, and also both of hepatocellular carcinoma and ICC. I think sometimes, for example, my presentation for pathological CR patient, is it necessary for conversion surgery or not? It's a very difficult question. However, sometimes, so achieve a complete response, sometimes patients, so a few viable region were left. I should receive conversion surgery to finish complete response. So it's very good question, but it's very difficult question. So I want to listen the next arrhythmia doctor's lecture.
Yeah, thank you.
No questions. Okay. Professor Itoi.
Okay.
Okay.
So Kaneko Sensei, thank you very much for nice presentations.
So
Thank you very
the
much.
last speaker is Professor Ari Izumi from Tokyo Women's Medical College. So he's a specialist in surgical field. Please start, Professor Ari Izumi.
Thank you, Chairman, for giving me a chance in this meeting. I'd like to talk the optimal indication for surgery in patient with ICC. ICC has a macroscopic classification like this mass-forming type, PI type, IG type. Mass-forming type is most popular. This classification is useful because the clinical finding, surgical outcome different. Recently, novel clinical guideline for ICC was published. 3 clinical questions for surgery in mass-forming type ICC. And treatment algorithm was made like this. This is clinical question 8. What is the best indication for hepatectomy? This answer was made. Prognostic factor for previous report. This is review of outcome. The 5-year survival rate almost equals 30 to 40% in the world. However, the survival rate was improved recently, especially in patients with single ICC, no lymph node metastasis. Professor Sakamoto sensei reported solitary ICC, the 5-year survival rate 54%, and Professor Kudo also reported 47%. In patients with no lymph node metastasis, 5-year survival rate over 50%. According to the combination of intrahepatic metastasis, multiple metastasis, and lymph node metastasis, in patients with no intrahepatic metastasis, no lymph node metastasis, 5-year survival rate over 60%. However, in patients with both intrahepatic metastasis, lymph node metastasis, the patient no longer survived 2 years. That's why the multiple and lymph node metastasis was stage 4B, but solitary and lymph node metastasis was upgraded into stage 4A. So therefore, this is the treatment algorithm based on the tumor number on the lymph node metastasis. In patient single ICC, no lymph node metastasis, surgery is recommended. However, multiple ICC with lymph node metastasis, surgery is not recommended. Chemotherapy is recommended. This is my ex-professor Ken Takasaki. He's pioneer of liver surgery. He succeeded anatomical hepatectomy in 1984. So this is our history. My ex-professor Yamamoto and Takasaki and Yamamoto have done so far 7,000 patients underwent liver surgery, including 400 cases ICC. Professor Yamamoto always says, let's improve outcome 20% by 2020. So that's why we tried to improve the 20% blood loss, 20% morbidity, and up to 20% survival. So we reported 2020 project. So improve mortality, morbidity, long-term survival in patient HCC. For ICC patient, we tried to improve 20% survival rate. So we studied 224 patients who underwent liver surgery between 20 years prognostic factor for survival. Evaluate, univariate, multivariate analysis. This is our treatment strategy. For mass-forming type, required anatomical resection because intrahepatic metastasis is often seen. PI type, mass-forming plus PI type required hemihepatectomy, bile duct dissection, lymph node dissection. Majority type required adjuvant therapy after surgery. As adjuvant therapy, 67 patient immunotherapy. Our immunotherapy a little bit X immunotherapy using active T cell transfer and dendritic T cell vaccination. 62 patient chemotherapy with TS1 using S1, 5-FU drug. And 97 patients underwent surgery alone. According to the univariate analysis, intrahepatic metastasis, lymph node metastasis, adjuvant chemotherapy, immunotherapy, a prognostic factor for survival and recurrence-free survival. According to the multivariate analysis, intrahepatic metastasis, lymph node metastasis, adjuvant chemotherapy, immunotherapy, significant independent prognostic factor. So this is survival curve according to the adjuvant therapy. 5-year survival rate up to 20% in chemotherapy group, immunotherapy group, compared to the surgery alone. Especially in patient single ICC with no lymph node metastasis, 5-year survival rate improved 20% chemotherapy and immunotherapy compared to the surgery alone. In single ICC with lymph node metastasis, the 5-year survival rate improved 20% chemotherapy, immunotherapy compared to the surgery alone. However, in patients with intrahepatic metastasis, multiple ICC, and no lymph node mets, multiple ICC with lymph node mets, there was no difference. So this is short summary. ICC without nasal intrahepatic metastasis, nor lymph node metastasis, this is best indication for surgery and adjuvant therapy. Single ICC with lymph node metastasis also is border indication for surgery and adjuvant therapy. Because of 5-year survival rate around 40%. ICC with intrahepatic metastasis, multiple ICC without lymph node metastasis, it's border indication for surgery, but further investigation for adjuvant therapy. ICC with multiple ICC and lymph node metastasis, no indication for surgery. Recently, JCOG means the Japan, Cancer Oncological Group Japan, reported this RCT. Adjuvant therapy, adjuvant TS1 therapy for bile duct cancer showed better survival rate and recurrence-free survival rate, especially in patients with lymph node metastasis. S1 was favored for that lymph node metastasis cases. So that's why this is I recommended this again. Single ICC without lymph node metastasis, best indication surgery adjuvant therapy. But multiple ICC, lymph node metastasis, no indication. Single ICC, lymph node metastasis, border indication surgery and adjuvant therapy. But this group is, I think, border, but further investigation for adjuvant therapy. Next is what is the best hepatectomy for ICC? This is a clinical question for HCC patient. For small HCC, anatomical hepatectomy is recommended. For larger HCC, hemihepatectomy is required. But ICC often showed intrahepatic metastasis like this via the portal vein. However, there are no recommendation for the extent of surgery. This showed there is no difference between the minor hepatectomy, major hepatectomy in larger ICC. For smaller ICC, there is no difference survival rate between the anatomical sectionectomy, hemihepatectomy, mean the larger hepatectomy, smaller hepatectomy. This is, I'm sorry, on the other hand, there are many previous reports. The surgical margin is the most important prognostic factor for ICC patient. That's why we sometimes underwent for negative surgical margin, IVC resection using VV bypass, or this case using ECMO for negative margin. On the other hand, this is a lap hepatectomy versus open hepatectomy. There is one of the meta-analysis. No difference between the lap and open hepatectomy for ICC patient. This showed Professor Conrad from United States. The surgical result no different for smaller ICC, but there is recommended for larger ICC, open hepatectomy is recommended. On the other hand, the Professor Kubo, today's chairman, he recommended lap hepatectomy is recommended for small ICC without vascular invasion, no vascular invasion, and normal CA19-9 levels because their result is very good. So 5-year survival rate, 100%. So this is our new chairman, Professor Honda. He is a specialist for lap surgery. So that's why the number of cases lap hepatectomy is increasing. So I'd like to introduce one case that he had case for HCC because he had a severe comorbidity, chronic heart failure, dialysis. And after taste, a liver tumor, this one in the segment 3 was recurred. This CT showed a little bit hypervascular, but no vascular invasion, no lymph node metastasis. The CA19-9 level within normal limit. That's why we underwent lap segmentectomy. Pathologically, this tumor cholangiocellular carcinoma because cancer cell, because very small tubular adenocarcinoma, the EMA staining positive for the luminal side. So between the 2 years, another 4 patients underwent lap, very like small ICC. The 2 cases showed high density on CT scan. This cancer was COCC, but these 2 cases typical ICC. As you know, COCC is one of the primary cancer because the cancer origin is different and imaging finding are different and survival rate different. So those 5 patients underwent lap hepatectomy. The 3 cases with COCC still alive without no recurrence. But 2 patients had typical ICC. 2 patients had recurrence, and one of them already died. So this is my conclusion, the extent liver hepatectomy should be chosen considering surgical margin. The lap hepatectomy is one of the options for small mass forming type and COCC. So again, this is my conclusion. This algorithm are very useful because treatment and adjuvant therapy can be determined based on the tumor number and the lymph node metastases. And extent liver resection should be chosen considering surgical margin. Lap hepatectomy is one of the options for those small mass forming type and ICC patient, COCC patients. Thank you very much.
Thank you for your nice presentation. Yes. Yes, please, yes, ma'am.
Okay. Yeah. Very nice. I mean, comprehensive, informative lecture, Dr. Arizumi. I just want to ask you, regarding the patient who will undergo surgery. So, in your opinion, is whether the biopsy is important, or I mean, in terms of the surgeons, or we using like imaging and tumor marker is enough to confirm that this is the ICC, because sometimes we found it's not easy to differentiate between HCC and ICC. And well, what is your experience regarding the combine, the mix between HCC and ICC? Thank you.
Thank you, Professor. Almost all cases, we don't need biopsy, just imaging findings. It's not enough. It's enough. I'm my comment. But if so, Professor Kaneko Sensei recommended if unresectable case for systemic therapy, we do the biopsy. It's okay.
So how many patients you found that mixed tumor, the combination HCC with ICC?
Just pathological findings.
Ah.
It's difficult to distinguish HCC, COC, ICC, and combine the hepatocellular current ICC case. So it's very hard to preoperate with this diagnosis.
Okay, thank you.
Okay, please.
Thank you. Excellent talk. I'm Shin Kaneko from Tokyo Medical Dental University. I'm very interested in surgical rejection for border indication patient. You mentioned that lymph node metastasis or interhepatic metastasis. So as I present conversion surgery, so you mentioned advanced therapy. I understand very much. So could you tell me your opinion about neoadjuvant therapy to surgical rejection?
Okay, thank you very much. So my small small opinion, as neoadjuvant chemotherapy is required for patient ICC with multiple intrahepatic metastasis or multiple lymph node metastasis. That is enough to surgery and adjuvant therapy.
Okay.
So that case is the good indication for the next treatment.
Okay, I see. Thank you.
Sorry, last one question, please. So you mentioned the importance of neoadjuvant chemotherapy. Now we can use GC durvalumab therapy with ICI and GCS therapy. It's a conventional therapy. What regimen do you recommend for neoadjuvant chemotherapy?
I don't have. I have no idea. I'm sorry, but usually, so for the non-resectable case, GCS and DC Durva is recommended. So, but if we want to shrink the tumor size, maybe DCS is recommended. But we want to control the disease, DC Durva is good.
Thank you so much.
Thank you very much, Professor Harrison. So now it's the time to close. So we'd like to thank again for four guest speakers. Thank you very much. ありがとうございました。東海領域のコンバージョン。
Thank you very much, the lecturers, moderators, and discussant. Next session will be free paper, Hepatocellular Carcinoma Clinical 1, chaired by Dr. Nobuhisa Akamatsu and Dr. Takamasa Oki.
その時はその時点で判断するかな。すごくいい質問で、いや、そういうの答えないんですよね。今答えがないっていうのが現状だ。あ、そうです。写真撮って。